Hello, ladies and gentlemen, and welcome to the first meeting and the first debate of the Stanford chapter of the Benjamin Rush Society. My name is Beau Breeze. I'm a resident in emergency medicine here at Stanford, and also the founder of the Stanford chapter of the Benjamin Rush Society. I'd like to thank our speakers for donating their time to participate in this very important and vital discussion about our nation's future. And I also wanted to take the time to thank our co-sponsors for this event, including the Stanford Democrats, Biomass, the Stanford Pre-Medical Society, the Stanford Healthcare Club, the Stanford Federalist Society, and a variety of other organizations that we'll acknowledge at the end. So it is my pleasure to introduce to all of you Jeff Anderson, the director of this Benjamin Rush Society nationally.
Good evening. Thank you for coming. I wanted to extend my welcome. It's good to see everybody here. We have some brochures up here that we welcome you to come up and take after the debate. Please feel free to take as many as you'd like and hand them out to anyone you think might be interested. And we look forward to hopefully a spirited and illuminating exchange of ideas here this evening. Welcome to the debate on the question, the federal government versus the free market, which can provide the more compassionate and efficient healthcare plan for America. Each side has two debaters, each of whom will give a 7-minute opening statement from the podium. Before the opening statements, we will have a vote on the question for the debate. After all four people have presented their cases, each debater will have 30 seconds to ask a question of the opposing side. The opposing side will have 2 minutes to answer. The questioner then will have 1 minute to give a rebuttal to the other side's answer. After each debater has had a chance to ask a question, the moderator, I, will ask questions that have been submitted by the audience and/or questions of my own. Please submit questions by filling out a card, which you'll find on your seat. And if you have a question, you've filled out the card, just raise your hand, and one of the Cindy or one of the other folks in the room will come by and grab that from you. After 12 minutes of, or so of a question and answer session, each debater will have 1 minute to offer a final rebuttal to tie up loose ends, and then 2 minutes to make concluding remarks from the podium. And then we'll then have a final vote and conclude the debate. I will now introduce the debaters. Debaters arguing for government-based solutions. Dr. Roland is a practicing family physician, owner of a small group practice in Burlingame, California, and an associate clinical professor of medicine at UCSF. He is a San Francisco native, a graduate of Ravenswood High School in East Palo Alto and Yale University, where he studied natural resources and public policy. After a brief stint as a quote-unquote policy hack and a year at Yale Law School, he studied medicine at UCSF and completed his residency training at San Francisco General Hospital. Dr. Roland's 20 years in a private practice of marked ethnic and economic diversity has convinced him that fundamental health finance reform is essential if our nation is to provide high-quality health care for all or any. Dr. Henry Abrams is a retired physician in Berkeley, California. He received his medical degree from Case Western Reserve University and is board certified in internal medicine, pulmonary medicine, critical care medicine, and occupational medicine. He was previously associate professor of medicine at West Virginia University, where his clinical responsibilities focused on critical care, chronic lung disease, cystic fibrosis, and medical ethics. He is on the national board and California chapter of Physicians for a National Health Program. Debaters arguing for free market solutions. Dr. Reid Wilson is a private practice physician in Beverly Hills, specializing in internal medicine and cardiology. He's an attending staff member at Cedars-Sinai Medical Center and a member of the Cedars-Sinai Bioethics Committee. He was founder and president of the Young Physicians Organization, the Young Physicians Charitable Foundation, and Beverly Hills Care, an independent physicians organization. He has served as a consultant to numerous pharmaceutical companies and healthcare research organizations. He serves on the executive board and is chief of operations for Doctors for Patient Care, an organization of physicians committed to the establishment of a healthcare system that preserves the sanctity of the doctor-patient relationship, promotes quality of care, supports affordable access to all Americans, and protects patients' freedom of choice. And finally, Dr. Zwelling. Dr. Marcy Zwelling is a respected member of the California medical community and a prominent voice in the struggle to improve the broken healthcare system. She is a quadruple board-certified physician specializing in internal, emergency, and critical care and quality assurance. Her practice, known as Choice Care, is designed to provide a higher level of access and attention to a smaller number of patients. All right, if you would please join me in welcoming the debaters. Okay, now as our first order of business, if you would please pull out your red, blue, or green cards and cast your initial vote. Again, we'll do a vote now and then one after the debate. If you think the federal government is the solution, please pass in a green card, free market, blue card, and if you're undecided as of now, please pass in a red card. Or I suppose if you're in between, you can pass in a red card. Maybe you could just, let's pass them toward the center aisle, shall we?
It's hard to tell the difference between green and blue.
It is. You don't see many reds, that's for sure. The other
Undecided?
undecided. Red means we have a chance.
The blues and greens are too similar.
Well, you're not supposed to be able to.
But they can't, they're having problems too.
Is anyone having trouble telling the green and blue apart?
It is a conspiracy. We agree.
Okay. Has everyone had a chance to vote? All right. And we will tally those up, and as well as the final vote, and announce both at the end of the debate. Okay. Let me now turn the podium over to Dr. Roland, the first of our four speakers. Please welcome Dr. Roland.
Thank you, Jeff, for the introductions, and thank you all for coming tonight to participate in this debate. I'm a family doctor, and I established my practice over 20 years ago based upon a few principles. I promised myself that I would provide the highest quality care I could, that I would do so in an evidence-based manner, that I would turn away no patient because of inability to pay, and that I would make a living doing so. I've been modestly successful at doing all of these things. That being said, with the passage of time, I've become increasingly aware of the barriers I face in creating what one could call a compassionate and effective practice. Over and over again, as I analyze those barriers, I find that it is a huge and complex bureaucracy that stands in the way of achieving my goals. A bureaucracy which seems intent on complicating care for patients and providers, and which often stands in the way as I try to serve my patients' needs. A bureaucracy which focuses more on denying care to the sick than on preventing illness. This bureaucratic opponent I face is not the government. It's the health insurance industry. Let me explain. This binder here contains the reports from the billing company, which I use to bill for my services. It lists 79 insurance companies or other categories of payers with which I have active accounts. What that means in practical terms is that I pay about 7% of my revenues to hire the services of the billing company. That's enough to hire another half-time physician. My mother, on the other hand, she's a Canadian, tells me of a recent trip to her doctor. After they had spoken briefly of my travails in dealing with the insurance industry, her doctor asked if he could see her medical card. He took it and swiped it through a device on his desk. "Well, no problem there for me," he smugly explained. I just got paid. The economic costs of my practice of having to deal with the private insurance industry are huge. Beyond the cost directly tied to my billing, my small practice of 2 full-time equivalent providers employs 6 staff members, at least one of whom we would not need if I had the ability to deal with a single payer. Yet the costs to me of this balkanized system pale by comparison to those of my patients. Increasingly, my insured patients are being forced to buy inadequate health insurance policies, so-called HSA-compatible policies, which sport high deductibles and copays, ostensibly sold to facilitate consumer responsibility and accountability. What happens on the ground, so to speak, is that this increasing patient responsibility, read financial vulnerability, results in many foregoing the care they need in favor of buying their groceries. They present with more advanced disease, fail to obtain needed medications or get important tests, and then if they have the bad luck to get sick, go bankrupt. Let me tell you about one of my patients. Mr. Pui has diabetes and most of its complications. A hardworking airline food preparer at the San Francisco airport, he neglected his diabetes for years. Office visits were rare. I'd long wondered if the expense of medical care was part of the issue, as he had insurance of the sort that required him to pay a significant deductible every year. And when I took over his care from his previous doctor, I noted that his chart had "sent to collections" stamped on it more than once. Mr. Pui first faced his diabetes in a serious manner when he was hospitalized for a vision-threatening fungal infection. Soon afterwards, because of layoffs in the airline industry, he was without insurance and decided to move to Tonga for a few years. When he came back, his diabetes was finally under control. "What happened?" I asked, incredulous. "In Tonga," he answered, "medicine is free." Our healthcare system is badly broken. Although the President's efforts will go a long way to correcting certain insurance company abuses, will provide coverage for millions who are currently uninsured, and will provide better support for public health and cost-effective primary care, we're a long way from where we need to be. I hope to tell you some more stories about my patients tonight, because stories bring life to the argument. But out of respect to the academic nature of this institution, and as Benjamin Rush himself said, because freedom can exist only in the society of knowledge, I will close with a few stark facts from the literature. Medical costs contribute to half of all personal bankruptcies in America. That's 700,000 a year. Yet 3/4 of those who go bankrupt in this way had health insurance. While Americans are struggling under the burdens of uninsurance and underinsurance, the 5 largest insurance companies in 2009 raked in more money than the industry has ever made in a single year. When you combine the profits they made with their direct administrative costs, ignoring for the moment the costs they impose on others like me, they spend more money on things other than health care than it would take to pay for health care for all uninsured Americans. And finally, a polling result. Twice as many Canadians believe Elvis is alive than would want to adopt our health care system.
Dr. Wilson?
I almost threw away my notes today because I saw the stock market go down 300 points, and I figured I'd just come in here and say, we can't afford it. You'd all applaud loudly, and that would be the end of the argument. But I kept my notes. Compassion and effectiveness, one usually thinks that both of those either one goes up and one goes down like a scale. Actually, in medicine, they both rise or they both fall together. I like to see results before I want to change any system. And I ask myself, what are the large systems in our country that we can use for an example? One of those would be Social Security. Very large system, affects everybody. And then I ask, when will Social Security's intake become less than their output? Because that is a sign of bankruptcy. If you ask the trustees of Social Security, that occurs in 2016. I don't want a system like Social Security. Then I said to myself, what's another large venture that the government is responsible for? And I said, how about the post office? The post office is permanently bankrupt. It loses $4.7 billion every year. FedEx and UPS do the same exact business, yet they work at a profit. And who would you rather wait in line, and who do you think is more compassionate? Do you find the post office compassionate or the DMV? I do not. Then let's take Medicare. Both of our opponents, I don't like to call them our opponents, but both of my colleagues who disagree with me feel that Medicare should be something we have for all. But Medicare costs money. And if you take a look and ask, when will Medicare be bankrupt, and you ask the trustees of Medicare, you will find it is happening in a little over 7 years. I don't find compassion. I don't find effectiveness in something that is going to be bankrupt. But then you say, well, we have the Massachusetts experiment. And they just started that 3 years ago. What has happened with the Massachusetts experiment? Let's quote the Boston Globe. The Boston Globe says it's untenable. What has happened with the Boston and the Massachusetts experiment? In 2007, they subsidized $600 million for the care of the people who couldn't afford it. What happened in 2009, just 2 years later? $1.2 billion. That's a 100% increase in 2 years. They've raised taxes. They still can't sustain it. The New York Times, hardly a right-wing organ, is saying this is not working. It's not working. We need something else. But this is not just a matter of money. It's a matter of efficacy, efficiency, and compassion. Remember, wait times might make a difference. What metropolitan city in the United States has the longest wait time now? Boston, Massachusetts. They have more hospitals than I think there's buildings in this city. They have more doctors than anywhere I think of in the world. Those are smart people, too. They're trying hard. You just can't do it. You cannot provide a quality system that has efficiency and compassion in that system. Now, much more important, I want to talk about results. Can you hear me this far away from the microphone? No. Okay, I'll try to stay really close. Let's talk results. What about mortality? What about the mortality of various cancers measured in Canada, the UK, and the United States? This takes into account all people. It doesn't just take into account poor people, rich people, it takes into account everybody. In the UK, in Germany, you have a 52% higher death from breast cancer, 88% higher in the UK than in the United States. In the UK, you have a 600% increase, 600% increase in death from prostate cancer than you do in the United States. In the Canadian system, you're saying, why are you leaving out the Canadian system? It's 108% higher. Is this compassion when you have a system which leaves out people to die? That's not efficiency. That's not compassion. Let's take another measure of compassion and efficiency. What about taking chronic care of people? What about all those individuals who need statin therapy? I'm a cardiologist. You're going to hear me talk about cardiology things. 56% of Americans who we think need statins can get them. 56% of the entire population. 29% of the Swiss. 23% of the Brits. 17% of the Italians. They all have national health care. I'm told that they can get anything whenever they want. All they have to do is go to a doctor, swipe their card. Why aren't they getting care? Let's talk about preventative medicine. After all, I think everybody here believes preventative medicine saves time, saves money, saves lives, compassionate. 9 out of 10 Americans, American women, have received a mammogram. 3/4 of Canadian women have. Nearly all American women have received pap smears. Less than 90% of Canadian women have. About half of American men have received PSA tests, prostate cancer tests. 1 in 6 Canadians have. About 1 in 3 Americans have received colonoscopies. 1 in 20 Canadians have. Which is compassion? Which is efficient? Which is providing care to our population? Americans are, I'm going to fade into cardiology here. What about the future? What about innovation? If you just take our 5 top hospitals doing clinical trials, that's more clinical trials than is done in any other single country in the world. That's American ingenuity. That's American free enterprise. And then finally, what about Nobel Peace Prize winners in medicine and physiology? Do you know that since 1970, more Americans have won the Nobel Peace Prize in medicine and physiology than every other country put together? Do you think this is a private enterprise system that's doing this, or do you think it's the government's doing it? We cannot afford to have government health care. If you believe in compassion and you believe in efficiency, if you believe in saving lives and having prevention, you go for a private health care system. Thank you.
Dr. Abrams?
I've never been in a debate before. I understand there's an opportunity for rebuttal later. So what I would like to do is just paint for you what is Physicians for a National Health Program and what do we base our views on. We believe that access to high-quality health care is a right of all people. There are 45 million people in this country who don't have health insurance, and we think that that's intolerable. And we believe that health care should be provided equitably as a public service rather than being bought and sold as a commodity. We view this as part of a campaign for social justice. It's not simply a question of health care, although when we look at health care, we find a lot to be dismayed at in the United States. We'll talk about the use not just of isolated facts, but the use of a more global look at the healthcare systems of other countries to see actually what their achievements are. And we don't come out looking very good, in spite of what Dr. Wilson says. We oppose for profit control. We're not opposed to profit in medical device companies, medical equipment manufacturing, drug companies. But we think that the delivery of health care, the relationship between a provider, whether it's a hospital, a physician, a nursing home, a therapist, that relationship should not be based on economics. We think it's governed by certain economic laws, but we think that it should be a nonprofit relationship because it is a service relationship. And we don't think that people should be going into medicine to make money. We do think that the entrepreneurial spirit that brings the application of scientific discoveries to bear on healthcare is sometimes advanced by the selfish interests of wanting to make a profit. But we don't think that the service and the relationship that takes place between a doctor and a patient and these other providers and a patient should be a for-profit relationship. And we especially oppose corporate control of medicine, and we recognize that large insurance companies, which are far more bureaucratic and far more restrictive than government-run healthcare programs. I mean, talk about bureaucracy. your blood pressure will really go up when you start dealing with private insurance. And these companies are bought and sold on the stock exchange, and they're answerable to their shareholders, and their interest is simply in a return on investment, nothing more or less. So we think that healthcare for countries should be financed by progressive taxation. Everybody has a responsibility to pay according to their means. Healthcare is expensive, and society can't, conduct healthcare without adequate financing. We actively oppose any changes in the healthcare system that are designed to maximize the profits of investors or the incomes of high-level executives rather than to serve patients. And we recently saw a dramatic example of the behavior of Anthem WellPoint, one of our most prestigious insurance companies and dearly loved by the people of California, whose CEO was awarded something like $14 million for her efforts on behalf of the public. We do stand, as I think Dr. Wilson so clearly does, and I'm sure Dr. Zwelling would agree, for the restoration of the primary mission of physicians, which is to act as professional advocates for whom? For our patients. Now, we all know that the U.S. has a healthcare system that is unsustainable. It's unaffordable by individuals, it's unaffordable by employers, it's unaffordable by society, as are some other institutions in their present form. And Dr. Wilson alluded to fiscal problems at the post office. He didn't talk about some of the other programs which are on great financial shape as far as I can tell. The government runs the military, the government runs many other programs. I don't see that they're going to run out of money anytime soon. So financing is a problem that can be addressed, and there are problems in the financing of Medicare and Social Security. Public policy, which is designed to create and administer and improve continuously the programs that serve society, should be evidence-based. And I'd like you to consider the market. What is the evidence about the market? If the market was so good, then over the last 100 years, we would have a very different track record than what we have right now. We're the only economically advanced country without health insurance that covers all of our people, and people die as a result of that. The Institute of Medicine said it was 18,000 people a year in 2002. More recent estimates, 45,000. Whatever the numbers, people die simply from the lack of insurance. So there's a lack of fairness, there's a lack of equitability. So let's look at other evidence. What is the evidence that we could use in terms of public policy? We can look at Medicare. Fiscally, Medicare has problems, but in terms of the health care access that it provides to the elderly and in terms of the high regard with which it's held and in terms of the security that it yields to the elderly in this country, Medicare is as sacred as motherhood and apple pie. We could look at the VA, which has very impressive health outcomes. We could look at international comparisons. And you've already heard about the disgruntled Canadians, but that's absolute bunk. It's rubbish. You can always find some individuals who are disgruntled. You can find people who have not had the same number of tests. Nonetheless, life expectancy is much greater. I don't think anyone in Canada went bankrupt in the last year because of health debts. I'm out of time, but I would say that medical decisions are best made by doctors and patients. The commitment of social resources and the allocation of those resources is best made by a democratic political process with input from health professionals. And that's why we advocate a single-payer plan for the United States. Not the current government approach, but a single-payer plan which would be much, much better than what our government has accomplished so far.
and Dr. Zwelling.
I'm told I have to put this down because I'm too short. Good evening. My name is Marcy Zwelling, and I stand here proudly as my patient's doctor. Our colleagues have stated that the United States spends twice as much as other industrialized nations on health care, $8,160 per capita. Yet our system performs poorly in comparison, and they, quote, leaves 46.3 million without health care coverage and millions more, quote, inadequately covered. While we could debate the number of uninsured, I would say that's reason enough to turn away from our government-regulated, overly mandated healthcare system. This is because private insurance and government bureaucracy and paperwork consume 1/3 or 31% of every healthcare dollar. Again, a quote. Streamlining through the free market and a consumer-driven system would certainly save at least as much as the $400 billion per year, enough to provide comprehensive, high-quality, affordable coverage that is accessible and compassionate for all Americans. Insurance is not assurance of a darn thing. Our emergency rooms are full of Americans with a card, a Medicare card, a Medi-Cal card, a Medicaid card, an insurance card. They sit for hours. Sometimes that card offers more in obstruction than it ever does for care. It certainly doesn't describe a compassionate, caring system. I believe that every physician in this country, not just those on this stage, would agree that paperwork and administrative hassle interfere with our opportunity to take care of our patients. And we all want to blame those daggone insurers. And I'm not here to condone a thing that they do. But most of their burden comes from the government. It comes from government provisions. It comes from government mandates. I would go so far as to argue that even with that ultimate single-payer system, a one government-run system, care could indeed be very inexpensive, certainly for the patient, for that patient getting care. But the care would be random, if not perfunctory, population-based, if not paper-based, and incredibly costly in terms of days of work lost, opportunities dissolved into a daily frustration and an expectant humanity traded for a massive despair and banal, thoughtless dissatisfaction. Health should be. It's an investment. It's a personal investment, and that all that must be available in the free market to help take care of oneself and one's future. Affordable and accessible care in a transparent marketplace offers choice and opportunity for that more productive day. I was a major in economics at Wellesley. I won't tell you when. But part of my thesis was about precisely this, the economics of healthcare delivery systems. We know that copays don't do much except perhaps trim a little bit of the demand. It offers an opportunity to tinker, but it doesn't provide a means for any patient to get an opportunity to purchase value-based health care, that experience that I offer as my patient's doctor. It certainly isn't anything about a pleasant medical care experience. In reality, copays often offer the patient the chance to sit anxiously in that waiting room, either in an emergency room or in a doctor's office, waiting for that 9-minute on average visit so that he can figure out what he can do to address that patient's medical needs. It generally is very unsatisfactory. Compassion just can't be sold in a 9-minute visit. Surveys have documented that the intent of doctors today is to retire early. We've already seen some of our best hands-on nurses emigrate from hands-on nursing into administrative systems. Evidence that our system just doesn't work, a system that really has very little room for compassion and for kindness. In order to control cost The economics tells you the patient must have a hearty piece of that last dollar expended. It's a fact. They've got to have skin in the game. The cost of care need not be expensive. In my community, a mammogram costs $75, a CT scan $250, an MRI $350, cash, no card, cash. And when do I get the results? Then, immediately. When does my patient get care? Immediately. I will give you an anecdote. My patient, with insurance, came to me because she had radicular pain. I gave her some steroids. It made the pain better immediately. She was ready to go back to work when her pain recurred. I told her that in order to take the next step, she probably needed an epidural and an MRI, but her insurance company said no. She needed to go to another doctor to get his or her approval for some medication before the MRI. She went to that doctor. She was given the medication and told to come back in 2 months. She went home, out of work. Couldn't work. She called me. What do I do? I said, simple. Go pay for an MRI, $250. She said, my gosh, that's less than a day of work. She paid for an MRI. I sent her to the gentleman to do the epidural, and she was back at work the next day. A productive day. That's what we deserve. That's what our patients deserve. That's what we sell. That's compassion. The product that a doctor sells their patient isn't an MRI or a lab test. It's the opportunity for a productive day. That's the right we give patients in this country. And that can only be found in a system where the patient has skin in the game, where they can find a doctor that will help them directly, immediately, with compassion and kindness for individualized, personalized care. Not a P4P system, not a paper-based system, not some kind of population-based system where you got to jump through whatever hoops to get your patient the care they need. Systems in government don't make compassion. Government sells process. It's not kind. Thank you very much.
All right, thank you. Each of the four debaters will now have an opportunity to ask a question of the other side. And while they're doing that over the next few minutes and answering those questions, I encourage those of you who have questions of your own to please fill out cards, and hopefully we can get to as many of those as possible. So let us start with first question. Each of these questions will be hopefully 30 seconds or less, and then whoever is asked the question will have 2 minutes to respond, and then the person who asked the question will have 1 minute to rebut that answer. So let us begin with Dr. Roland. Would you please ask the first question of the other side?
Okay. Dr. Wilson, I want to say I wish my patient...
That's both of us.
Well, I have comments for both of you, but a comment is for both of you. But I want to direct to you, I wish my patients were affected by the ups and downs of the stock market and were made some impact on them, but it doesn't. My patients are more like the guy who called me yesterday, guy with asthma, who called me saying, couldn't I please help him sign a form so that he could designate his nebulizer as essential life-supporting equipment so he could get a discount on his PG&E bill. How can a man in that kind of financial position, a man who struggles to pay the basic PG&E bill for his small little apartment, how can that man, he can't come up with the $2 copay to pay for his asthma medication, let alone $250 for an MRI scan. How do you deal with that patient? And that patient is not rare. That is
Thank you, Doctor.
Millions in this country.
I'd like to answer that question. In my practice, you probably heard that I have fewer patients because my patients pay me. Over 10% of my patients are scholarship patients. They don't pay me a dime. Not a dime. Not one dime. And I don't accept anything from their insurance company if they have insurance either. Because I can provide them compassionate care, because on one end, I make a living, and it is my absolute privilege to be able to give back. In government-based systems and in Medicare systems where my colleagues are going bankrupt, and they are, and they're leaving the practice of medicine every day, They don't have the time to give back. They're working from 7 a.m. to 10 p.m., and they can't feed their children. When I converted my practice over to the kind of practice I have, I was seeing patients at midnight. That's not compassion. And no, I didn't have the time to give back. Many of us doctors would love to be able to give back. I have that privilege. I do it every day. And mind you, some of my patients not only don't have a pot to piss in, but I give them the pot to piss in because it's my compassion that helps them.
Did you take their MRI too?
I have done that, yes, ma'am.
We'll have questions from the audience, I think, later.
You bet.
Dr. Wilson, did you want to add anything?
Can I add to the same question?
Yeah, I think there's some time left.
Okay.
Is there not?
You know, we actually have an example of
30
that
seconds.
from the Massachusetts system. Everybody said, since everybody has to have health care in the Massachusetts system, everybody is going to get care. There's still 200,000 individuals who do not get care, have any health insurance in the Massachusetts system. And now, where there used to be free care, just like Dr. Zwelling said, you must make a copay. And many, many patients who used to get free care and get good care are getting no care. This is well documented in Massachusetts because they can't afford the copay, which is, it can even be $20. So to point out one person probably is not a good anecdotal experience. I could provide thousands of anecdotes. What I've provided you for is a patient population-based, what happens in America, not just to one doctor's one patient.
Okay, Dr. Roland, you have 1 minute to rebut that.
Well, I think that I'm certainly no supporter of the Massachusetts plan. I think that it's a dismal failure, and I think that although the recent proposals are going to help a lot of people, I think they're ultimately doomed to fail because they depend upon a failed system. I have a lot of respect for what you give to your patients, and I think there's nothing wrong with what you do. But the fact is, the drug companies, the laboratory companies, the medical device companies, I went and tried to price an MRI today. The best I could find in my community for a lumbosacral MRI was $615. Okay, so it just doesn't happen that there's a lot of people giving away, and there's a lot of people who have need. And so what I really support is a system whereby we eliminate the waste in our system. We eliminate the bureaucracy, eliminate what the insurance companies take and don't give any value.
All right, thank you. I'm going to try to hold all of you to the time limits just so we can have a nice, brisk debate. And we have James Egan, the Benjamin Rush Society's program coordinator down here, keeping close tabs on you. So please watch his signs, if you would. The second question will be asked by Dr. Wilson.
You just said that you do not want huge bureaucracies, and my question is as follows. The #1 employer in the world is the Chinese Army. They have 1 billion people, and they have make a 2.3 million man army. The second largest employer is the Indian Railway Service. They also have a population of 1 billion. The third largest employer in the whole world is the National Health Service of Britain. They have a population of 60 million, which is 1/5 of ours. How do you think having a government-run, single-payer system will eliminate bureaucracy?
Either one of you is free to respond.
You'll never eliminate bureaucracy. I think you're holding up a straw man. I think the question is, to understand the role of bureaucracy, we should just compare two simple numbers. What is the administrative waste under private health insurance compared with the administrative waste under Medicare? And I have no doubt that there are glaring inefficiencies in Medicare. The main problem with Medicare in terms of funding is the fact that it takes care of the sickest, most highly consuming segment of our population. If we had Medicare for everybody, Medicare would have a much more balanced risk pool, everybody would be in it, and it could be funded on a much better basis. We could afford to give much better care to the people of this country without paying a dime more than we're paying now, and we would have a much fairer and more just society. So I don't think that, your example really helps me to understand how to make our healthcare system better.
I would add that really when we're talking about healthcare finance and the issues of healthcare finance, the goal is not to minimize the expenditures of the federal government. The goal is to minimize the expenditures of the nation on healthcare. We want the highest quality healthcare with the lowest expenditures possible as a nation. And so we have to take into account what people pay out of their own pocket, what insurers pay, what government pays, et cetera.
Dr. Wilson.
You asked a question on comparing efficiency with Medicare versus the private practice of medicine. And actually, just this last year, the Manhattan Institute has done just that. They estimated, if you take into account the increased taxes, administrative costs, and also the cost of actually providing goods, that Medicare costs 24% at minimum of each healthcare dollar for administration and those factors. Private insurance costs 11 to 14%. That study's been done.
And just
Thank
to
you.
add, if
Oh,
I may.
go ahead. Well, actually, let me.
Are we out of time?
Well, it's really just
Okay,
when
I
you
apologize.
ask your question, you'll.
No problem.
All right, Dr. Abrams.
Well, my question could be to either Dr. Zwelling or Dr. Wilson. And the question really concerns looking at the healthcare needs that people encounter in their lives. They need hospitalization, they need medications. If they have chronic illness, those medications can run to thousands, if not tens of thousands of dollars a year or sometimes a month. So yes, it's possible in certain circumstances to pay at the point of service. My question is, does the hardworking janitor toiling in the church with a family to support deserve the same medical care throughout his or her life as a Wall Street executive or a banker? And if so, how do you envision providing that under a concierge medical system?
Thanks for the question, because that's precisely what I offer. I don't have anybody in Wall Street in my practice at all. It's a very middle-class practice. And my patients make that decision every day because I absolutely respect their opportunity to make choice. You know, being poor doesn't make you stupid. These people deserve our respect. They get to make decisions about their life, and they can make decisions about their life. They make very good decisions about their life, as a matter of fact. So offering them the opportunity of choice and the opportunity to select what they want to do for their own personal investments in their life, for, as I said, their more productive day, is a wonderful opportunity for them. So indeed, precisely, that is what we do. I believe that every person, and I never ask what kind of insurance anybody has, because that doesn't matter to me. I don't ask how much money they have in their bank account because that's irrelevant. We do talk about the cost of care because what I provide has to have a value. And if I can't tell them what that value is, then they shouldn't buy it. They shouldn't make that investment, regardless of what it is, even if it's a 10-cent aspirin. So I give them information, I give them opportunity, I give them choice, and they make the choices for themselves. And mind you, my patients are absolutely positively not rich. We always make decisions regarding care with respect to value. But that can only be done even if the patient is a Wall Street banker, if in fact they have skin in the game. In fact, that's one of the reasons that we waste so many resources. My patients don't have that second MRI, the one they had last week that their insurance company or Medicare paid for, and the one this week that Medicare pays for because their doctor or the hospital or somebody was too busy to go get it. Because they think it doesn't cost anything, so they'll go spend another hour in a machine. But if they actually pay for it, they want to know why they're getting it. They'll tell you, I just had it, and they'll actually bring it to me because they paid for it, it has value, and they want me to know about it.
Dr. Abrams?
I don't feel my question was addressed with regard to expensive medications, hospitalization, critical care in the ICU, end-of-life care. I think that you took an isolated portion of the doctor-patient encounter or of the patient's life experience. And, you know, if you want to just put on blinders and look at a certain part of it, you can make your approach quite relevant. But I don't think it's relevant to the world that most patients and most families live in, and I really think that we're sort of not in the same universe at this point.
Dr. Zwelling, it is your turn to ask a question.
Certainly. My patients, God forbid, go to the emergency room and they end up sometimes in the critical care unit. But what data tells you is that patients who receive direct care actually need less care. They don't go to the emergency rooms less often. Their lengths of stay in hospitals are less. So their care is less expensive because they've gotten what they need. With respect to insurance necessary for those expensive things, if we were talking about legitimate insurance, an actuarial bet to protect you from the catastrophe of financial disaster if you get sick, yes. I absolutely believe in insurance, but that's not what we're talking about. First dollar coverage for a doctor's office visit is not an insurable event. So if you want to talk crackers to crackers and dollars to dollars, let's talk dollars to dollars. An insurable event is a potential catastrophe. A doctor's visit is not insurable. And so when you talk about the economics, those are two separate things.
Did you have a question for the other side?
Oh, I'm sorry. I thought I was readdressing his. Yeah, my question is very simple. Name me one opportunity that the government has ever provided that's compassionate.
Opportunity?
We're talking about the compassionate care that a single-payer government system would provide. I'd like to know one time when you've ever seen the government offer a compassionate opportunity. One time.
The government's role is not to be compassionate. The government's role is to administer social programs for the benefit of society according to the wishes of the people who live in that society. I don't think that you could take away Medicare from the people of this country. I don't think you could take away the National Health Service from the people of Canada or Great Britain. It's not their wish. So the compassion is the encounter between the providers and the patient. And we do not have an environment right now that's conducive to compassion. And the environment that you're describing, to me, it's a nice environment, but it, to me, smacks of the horse and buggy age rather than the century and the universe that I live in. So I think that we can have a system which is efficient, which is sustainable, and which fosters the sanctity, as you put it, of the doctor-patient relationship. I think sanctity has a little bit of a religious overtone, but I think that absolutely a moral and ethical responsibility on the part of both doctors and also of the citizens of this country to provide security, health security, so that people can lead productive lives, so that our businesses can compete, so that our taxpayers feel that they've been treated fairly. I'm not a defender of any of the current government programs other than to say that the Medicare points away and the VA point away. They should be expanded, they should be improved, not Medicare in its current form, but we could have a Medicare-like system. It's the only system of social insurance for health care in this country that I would hold up as an example of what we could do for all of our citizens.
Rebuttal?
We're in health care. Thank you. Am I out of time?
Yeah, I think you're out of time.
Okay, well.
May I answer? May I respond?
Yes, please.
The debate is sort of over because our gentleman, my opponent, just said the government's responsibility is not compassion. That is one of the titles of this debate. Which system is more compassionate and efficient? I've gone through the numbers on efficiency, case closed. My opponent has just gone through compassion, and he said it, case closed. Now, as far as the physician providing care, I'm very interested in how the physician is going to provide care when we're supposed to be approximately 80 to 100,000 physicians short in the next 10 years. Who is going to take and provide the passion and the compassion to all these individuals who you say the government is not responsible for? What medical student is going to pay $300,000 for a medical education and they get paid government wages? Where is the compassion in that? Where is the efficiency? Thank you.
All right, thank you. Now, turn to some of the audience questions here. First question, is why did the Minister of Health of Canada travel to Florida recently to get immediate care? Why do patients from Canada travel 100 miles a day to Detroit, Michigan for immediate medical care? This sounds like a question mostly for Dr. Abrams.
I didn't write that question.
Nor did I.
And Dr. Roland.
You know, I'm not going to comment on what any individual's motivations are because I frankly don't know what they are. What I can tell you is, I mean, I told you earlier, more Canadians believe Elvis is alive than want to adopt the U.S. healthcare system. That in Canada and Great Britain, the left and the right wing both support their national health programs. These are programs which the people in their countries believe in. Canada spends 50 cents on the dollar that we do. And they do have some weights for some things. At least, however, you can go to a website in Ontario and find out how long it is. But you know, I have patients. I have patients. Their wait is forever because they simply can't get services. You know, or I actually pulled some papers out today from my office. These are two patients who I got letters from their insurance company today. These are basically setting them up to have their insurance rescission take place. One is a 14-year-old who had a UTI, and because of her prior UTI during the control period, she had pyelonephritis, which apparently her mother didn't report because she only reported her asthma as a condition. She's going to lose her insurance. You know, it's just, it's immoral. It's immoral that this behavior.
The moderator ask
One
the man
second,
to answer the question?
Dr. Wilson.
He needs to answer the question. The question was, why did the gentleman come down to New York City to have his heart surgery? No.
Let's please leave the answers to the folks up here. Go ahead, Dr. Abrams.
Yeah, my answer is who cares? It's not a reflection on the Canadian healthcare system because I could give you a very large number of anecdotes as well as a lot of persuasive statistics that more Americans have gone to Canada to get their care and to get their medications. So, you know, you have different takes on the situation. I think the reality is quite the reverse of what Dr. Wilson alleges it is.
Dr. Wilson, quickly.
I can tell you what happened in Canada it happens to be the Prime Minister of Newfoundland, and he is an ardent supporter of the Canadian healthcare system. But when asked why he did it, he says, "It's my body, and if I would have gotten in Canada, I would have been put in the front of the line, and then people would have complained about that too." There is not an equal system in Canada. If you're just like every country, if you got a string and you pull it, you will be taken care of first. This is no different than we are here. Anyone who thinks that more Americans still go to Canada for their health care lives on Mars. So I guess your past statement that we live in alternate universes is true. We must, because Detroit has about 14 MRI scans for each one in Toronto. I don't go up to Toronto for an MRI scan because I know there's 14 in Detroit. I come down to Detroit. That's how some of them stay in business from the Canadian system. In some provinces, you need to have a lottery system to get a doctor. In order to see any doctor in Canada, you need a primary care physician. There are not enough in Canada. Outside of Toronto, they hold lotteries so that you can get a primary care physician, so you go to see a doctor.
Thank you.
And furthermore, it is indeed a system where people have to lay out the bucks. For the most part, if you want to get into your doctor, I'm told it takes about $100 under the table, and then you'll get your visit a little bit sooner. It is really an important Canada.
Thank you. I want to move on to the next question so we can get through as many as we can from the audience. This is sort of on the other side. How should we address the fact that despite spending more than double the healthcare dollars that other countries do with single-payer systems, our medical outcomes are not statistically better? Sounds like a question for Dr. Zwelling and Dr. Wilson.
First of all, that fact is not a fact. The World Health Organization is a fascinating organization, and I love their facts. Infant mortality, you've heard this one, we're 37th in the world. You've heard that one? It's a lie. Here's how they measure infant mortality. In this country, we measure every single person that is born from the time of their birth. Dead or alive, they are measured. And then when they die, obviously, that is a mortality. In other countries, they do not even call it a birth unless the fetus, if you will, is at least 9 months in gestation. The data is not equal. In fact, we are the greatest country in the world. This is the greatest nation. Would you raise your hand if you're willing to go to France, England, or Canada to have your heart surgery? Who in this room is willing to do that?
Wow, that's great.
Wow.
Can I give
That's great.
can I give I don't want to do audience participation yet. This will be.
I'm shocked.
The next thing is Jeopardy for $10. The reason also, the WHO data is from the year 2000, by the way. They don't do it anymore because they don't believe in it anymore because too many subjective things. But they also count accidental deaths. We have 10 times the accidental death rate of a place, and that could include gang warfare, automobile accidents, so we have a very mobile society. We have 10 times. That's young adults. That number gets played on statistics. And if you take that factor, just that one factor, we are longer than any other industrialized nation in our lifespan.
Okay, let me go on to the next question here. Right back to Dr. Wilson, we have a question directed to you. It's a three-part question. How would you explain the position of the U.S. in infant mortality in comparison with the rest of the world? What is the colonoscopy rate in this country for those who are uninsured? And how much does FedEx charge to deliver a letter?
In reverse, $1.19, A, and all of the above. I mean, I don't understand each of those questions. How much does FedEx charge for a letter? I mentioned FedEx only because I was comparing it to the U.S. Postal Service, who loses $4.7 billion a year. So whoever asked the question, can you please just rephrase it so I can answer your question?
I can rephrase it.
Yeah.
USPS charges 44 cents for that same letter, and it's very easy to mail it. So I think you were kind of comparing apples to oranges by comparing FedEx to.
It doesn't cost that if you take into account that you're paying taxes of $4.7 billion to subsidize that letter.
But we're also subsidizing FedEx. Well, leave that aside. But the other thing that I'm really concerned about is what is the colonoscopy rate for uninsured patients in this country? I can tell you, I'm a public health doc, and my patients can't get a colonoscopy unless they have a reason for it. And the United States Tax Force, Preventative Tax Force, actually says that, you can do other cheaper testing. And I believe you that your concierge practices, that doesn't happen. But what is the colonoscopy rate since you compare us to Canada?
I'll be.
Okay, thank you.
And
Thank you.
we'll answer that. We'll answer
speakers answer
that. Actually, in Los Angeles County, where I am the chairman of the Los Angeles County Hospital Commission, I give a lot to the public health system. And in that public health system where those patients have Medicaid, the colonoscopy rate is 0. Do you know why? They can't find any doctors to do them. Medicaid, I said they were insured by the government. The colonoscopy rate for those insured by the government is 0. I find it appalling and abhorrent, and I'm trying to change that system and bring in physicians who will donate their time to give those people in government systems the same colonoscopy that I provide for my patients. But the answer in a government-based system is 0.
No,
Thank you.
you've got it wrong. It's health care. The problem in our
I
country...
live it. I'm there.
No, I'll tell you where you're wrong. The health care for poor
Right.
people is poor quality health care.
We have a certain time to ask a question I would like to add to Dr. Zwelling, and then you can have a
Well,
second.
no,
It's
we're
over.
over
Your time's
time.
over,
We're over
my
time. Very quickly, please, Dr. Roland.
Yeah.
I want to move on to another question, so if you could please make this quick.
Well, health care for poor people is poor quality health care. We're not advocating healthcare government programs for poor people. We're advocating government programs for everybody.
So that everybody's grade can be zero?
No, everybody's will not be zero when everybody is in the game.
Okay, let me go.
When the rich people and the poor people get the same care, the standards will be raised.
Let me go back to Dr. Abrams and Dr. Roland with this question. We don't think monopolies work in any other realm of life. Why would they work in healthcare?
Well, you know, let me just comment a little bit about the nature of the healthcare system in our country. The nature of our healthcare system is we don't have a system. You know, what we really have is that for people who are veterans, we have the British system because the government pays for everything and everything is taken care of free of cost. For people who have insurance through their jobs, we've got a poorly regulated system of Germany. If you're over 65, we are Canada. That's exactly what we are. We have a government-paid program that delivers services through the private sector. That's Canada. Unfortunately, for the tens of millions of people who don't have insurance company, we really do have a free enterprise system. We have exactly the same healthcare system as they have in Burma. And, you know, the problem is we cannot survive as a developed, advanced, moral country if millions of people in this country have to have the healthcare system of Burma.
Thank you. Did you want to respond quickly?
Yes. First of all, I'm not saying that we have a perfect system. Things always need change. Things always need evolution. This bit with 46 million people, Americans not having insurance is simply not correct, even by the person who did the statistics. She said 10 million of these people are not American citizens. She said 8 million of these people make between $50,000 and $75,000 a year. They can afford insurance. She said 8 million of them make over $75,000 a year, far above than poverty level, and they can afford insurance. She said 45% of these people will have insurance in 4 months. It's a transition in between their jobs. So why should we change a system that has been so successful? Colonoscopies in America, 1 in 3 people eligible have gotten it, 1 in 20 Canadians. Why should we change a system for 6% of the people when 94% of the people are covered? Why don't we have a safety net for the 6% who don't?
Thank you.
And just one more comment.
Let me just move on to the next because
Okay.
we're getting behind. Sorry.
That's okay.
I just want to make sure to try to get through as many as possible. Dr. Wilson and Dr. Zwelling, how would you deal with the problem of the uninsured or people who cannot afford care?
There are a lot of systems that we can use, and I'll give you the example of how I deal with my patients who pay for my practice with a scholarship. Their care is free from me, but in exchange, they volunteer at a 501c3 in the community. Because I respect them so much as people, I want them to earn their health care. And so we have actually funded many private and public programs in the city with their time or their family's time, because some of them, quite frankly, are too ill to do the work themselves. And so we've been able to actually get them back to work and get them to a situation where they could afford insurance if that's what they want to purchase. So it's a scholarship program, and we're now turning it into a foundation where we will take people who are uninsured, or if you want to call it underinsured, who want to get care, and companies, large companies, will help broker this system. And in a cash-based market, and I'm going to help you find that MRI for a lot less money, by the way, where there's transparency and competition, you actually do drive down prices remarkably, and you can provide that care. Actually, the companies love to broker that because it keeps their health care costs down. And now you have people who are uninsured getting care, the same exact care as everybody else. They're proud, they've earned it. And we have foundations that actually now are supported. So it works very well, and that's a very specific example. It's up and working today.
And also, if you have someone who can't even do that, but the government should be there. That's what government is actually for. Government is for those people who are truly needy. That's what we believe in. That's compassion.
Okay, let me ask a question to the other side. Government cannot manage Medicare, Social Security, etc. Why do you think they can manage health care, and how would you control costs?
Well, I was reminded that I gave the impression that Medicare was the only program that the government runs that, is beloved by the people of this country, or at least to the extent that they would be unwilling to let it go. And then I was reminded, no, I forgot about the police department, the fire department, public education, our defense forces, et cetera, et cetera, et cetera. So there are examples. All of those programs could be improved. Tell me again
The question was, government cannot effectively manage Medicare, Social Security, et cetera. Why do you think they can manage health care as a whole, and how would you control costs?
Well, I think that one of the things that's been most destructive of Social Security and Medicare have been attempts to privatize it and to subject it to market forces. So I think that actually we're seeing programs that have problems, but I don't accept the fact that government can't manage. I think can and has managed are two different things. I think that the management of those programs has come under various administrations, and some administrations have not treated the programs as fairly and as supportively as others. But I think that the people of this country are smart enough that and idealistic enough, and we care enough about our communities, we care about our families, we care enough about each other, that we can come together to create and run social programs that will do all of us good and make us a better country. And I think that when those programs run into problems, we know how to solve those problems. I would like to just add one other thing, and that is I wonder why in the United States we have so many extra, unneeded, unnecessary colonoscopies that don't really add value. They just run something up people's backside, and somebody makes money as a consequence. And I would ask, in countries who have fewer colonoscopies, is there higher mortality? The answer is no. Is there a shorter lifespan? The answer is no.
Thank you. One last question from the audience, and this is for anyone. The practice of medicine is for profit from the physician's point of view. Are you concerned that making the practice of medicine subject to government will discourage the best and the brightest from going into medicine?
I actually feel that if the government were involved more in medical care and in the finance of medical care, that we would be able to make use of our collective decision-making about where we put our dollars. In fact, the most recent move that's taken place in Washington, again, so many aspects of it I don't support, but one of the things that's remarkable in it has been a tremendous increase in the support for primary care services, be that in community clinic support, in support of innovation, in delivery of care systems, and in simple increasing the salaries of primary care providers. I think that the government has the ability to make those kinds of change in a way that industry, the insurance industry, has utterly failed.
Thank you, Dr. Roland. Anyone else like to take a shot at that? Go ahead, Dr. Wilson.
When the government gets involved, you do not have greater thought processes, you do not have greater spontaneity, you do not have the best and the brightest. I gave you the statistics on where clinical trials are done. I gave you the statistics on Nobel Peace Prize winners. Those are from a private system. We don't have smarter Americans. We have a private system. We don't have, an American is not smarter than a Brit, is not smarter than a Canadian. But where are the peace prizes? Where are the innovations? Let me finish, please. I'm a cardiologist. Where do you think ACE inhibitors were developed? Where do you think statins were developed? Where do you think coronary artery bypass grafting was developed? Where do you think PPIs were? Where do you think the H2 blockers were developed? Where do you think SSRIs are developed? Where are all these? Pardon? Government funding. There might be government funding, but those are We might have government funding in some of this, but these are for-profit corporations who are making those drugs. It costs roughly, they must...
Thank you. Let's please let Dr. Wilson finish
Let
here.
me finish.
I
When
appreciate
the
your
government
enthusiasm.
becomes involved, we have a problem. For example, I know this is passionate to a lot of people here, but if you could just please let me finish, I'd appreciate it. I know you have opinions. I know they're strong, and we can talk forever about it, but I'd really appreciate it. Someone brought up the U.S. Preventative Task Force. They recently recommended that women not receive mammograms under age 50. We used to find, before we instituted mammograms, we used to find them when they were 3 centimeters in size. Now we find them with mammograms when they're 2 centimeters in size. The earlier you find them, the higher chance you have of curing them. Please, because I didn't get to talk sometimes.
Quickly, please.
The U.S. Preventative Task Force did not have an oncologist decide that. They did not have a radiologist decide that. The state of California has now adopted that for all Medicaid women. All the rich women will continue to get mammograms starting at age 40. All the poor women will now no longer be able to get them below the age of 50. I have taken care of too many women who could have died and who have children who could have been affected to let that happen to my population, no matter how rich they are. That's the government.
Thank you, Dr. Wilson. Dr. Roland, 30 seconds.
Less than 30 seconds. The country with the most per capita Nobel Prizes in technology or in medicine is actually not the United States. It's Israel, which has a socialized health system.
And as much of Israel is going to a private, and most of their government is going to a private system, I'm intimately knowledgeable of what's happening in Israel.
Okay. We now have a quick 1-minute response time for each of the 4 speakers to just kind of wind up or tie up loose ends, deal with things that they may have wanted to respond to along the way. Dr. Zwelling, you have the first minute.
Sure. Government is about process and it's about procedure. It's not about individuals. But medical care is about individuals. Health care, and medical care is about personal choice, personalized options, and individual needs.
Dr. Zwelling, I'm sorry to
Yes.
interrupt, but I just want to make sure you're aware that this isn't the closing.
Oh, you want me to just rebut?
if you have a...
I apologize.
Okay, no problem.
In rebuttal to some of the things that were said, have you been to Europe lately? I have. It was my first trip, my very first vacation ever, and I spent time in Germany, and I spent time in Czechoslovakia, and it's a lovely place. In fact, one of the greatest businesses in those cities that I was in, Prague and in Krakow, is medical care, private medical care. In fact, the streets are lined with clinics, lovely clinics. And when you talk to the people, including the guides that were taking me around, who weren't rich, they were just people who live there, I asked them, where do you get your care? And they said, we buy it at the clinics. So what you understand about these single-payer systems is really not honest. It hasn't been portrayed to you. This is the same is true in England, by the way. In Canada now, you know that in Quebec, we now finally have private medicine that is allowed. So in every socialized system that is out there, private medicine has actually eked in and has now become the more predominant method of care. And I wanted to add that to one of the comments that was made earlier.
Thank you, Dr. Zwelling. Dr. Abrams, just any quick things you wanted to rebut? You have 1 minute.
We have a problem that has to be addressed on a societal level. The problem is that we have too many people who don't have access to health care. Our health care is becoming unaffordable. We have an unsustainable system. Nothing that I've heard and nothing that was offered in the recent legislation in Massachusetts or in Washington addresses a plausible way of controlling health care costs. We have to set up a system that's affordable for the people of this country, where everybody has equal access to health care. It is the responsibility of those of us in medicine to make sure that the actual choice of procedures, the medications, the formularies, provide care that is up to the standard. Those are not government decisions, but they will be implemented through social programs. After all, resources are not unlimited. So,
Thank you.
Okay.
Thank you, Dr. Abrams. Dr. Wilson, 1 minute.
The key facts that I think I take from my opponents in the debate is that government is not compassionate, as stated by them. Number one.
Not true.
Number two, that government will not have a large bureaucracy, and I've given you an example of the National Health Service. Number three, that evidence shows that a single-payer system is more cost-effective and efficient in prevention, chronic care, and mortality, of which I have disputed and given you actual facts, not feelings. And each of these instances, the purpose of the debate was to show you which is more compassionate. I think saving lives is compassionate. Which is more efficient? The system I postulate doesn't go bankrupt. That is efficiency. I can push all the bankrupt systems I want to and call them idealistically the right choice. But unfortunately, we live in a real world. We must pay our bills. We have a $1 trillion deficit this year. If I put down $1 on this table every second, it will take me 32,000 years to pay off that $1 trillion deficit. The young people in this audience should be afraid of this, very afraid.
Thank you, Dr. Wilson. Dr. Roland. Dr. Roland, 1 minute, please. Please, let's not talk for minutes. Dr. Roland, go ahead.
I just make a couple random comments. I actually loved the example of the FedEx and the UPS versus the Postal Service, because that really is exactly a great analogy to the insurance companies. While FedEx and UPS take the cream off the U.S. Postal Service, the U.S. Postal Service does the duty of delivering the mail to the roads that are 30 miles, a letter to a road that for 44 cents that's 30 miles away from the nearest town. You know, the other thing that, as far as a trip to Europe, I was in Europe 2 years ago. I was in England. And one of the things that struck me there about the healthcare system was the headlines in the newspaper. They were having a public debate at that time, not about what to do about the uninsured, because that debate is answered, but about whether they should offer in the National Health Service 1 or 2 rounds of in vitro fertilization.
Thank you. We'll now move to the closing remarks, and then we're going to follow that up with our final vote. These are 2-minute closing remarks, and they'll be delivered from the podium. Dr. Zwelling, you're up first.
Sure. Thank you very much, first of all, for having us here. This has really been fun. It has. Access to care is not about a card. Access to care. Hello, how can I help you? That's access to care. Government is about procedure. It's about process. It's just not about compassion. Health is the thing most individual. It's owned by you as a person. Indeed, the example that was just given, 1 or 2 rounds of in vitro, who should decide that? The government? You know, the golden rule is a very important rule. He who hath the money rules. The payer rules. The payer makes the decisions. I want to make my own, good or bad. If I fail, it's my failure. If I win, I get to own it. I've earned it. My patients, the public, your friends, your family, deserve that respect. They deserve that integrity. That's the self-esteem. That's the better day that I try to sell my patients every single day. That's the opportunity we afford in this country. The government cannot provide that opportunity in healthcare. It's about process. It's about systems. And we can argue till the cows come home about whether they do that well or not. But clearly, they don't belong in an exam room. What I do with my patient is between 4 walls and a closed door. And the government does not belong in the room. Thank you very much.
Dr. Abrams.
I don't want the government in the exam room either, but I sure want somebody to open the door and let the patient in. And I know that if we have concierge medicine, you know, we've talked about shortage of primary care doctors in this country. This is an untenable system. It doesn't cover the entirety of health care. And we as a society need to take responsibility. There's nothing to prevent Dr. Zwelling's patient who wants the second in vitro fertilization from getting it. The question is, does the insurance system cover that? In this country, there is nothing more heartless, more ineffective, more wasteful, more intrusive, and less compassionate than the system of private health insurance that we have now. The market is not the solution. The market has run our healthcare system close to being worthless, I think, in terms of the money poured into it for the return that we get in terms of healthcare delivery. And I think that we need to be concerned not only about what happens between a doctor and a patient. We need to look at health in its entirety. We need to look at public health. We need to look at immunizations. We need to look at education. We need to look at nutrition and diet. But right now, we have people who are denied access to health care. We have providers that are driven by money, and I'm not accusing anyone in this room, but we know very well that there are many colleagues out there who are making decisions based on remuneration, who are gaming the system. There are many hospitals who are gaming the system, and they're forced to do it. And the market is the problem. We need to make healthcare a nonprofit public service, and that's the way we will provide health security for the people of this country. And the doctor-patient relationship should not be based on skin in the game. Everybody has skin in the game. People pay their taxes. Even undocumented workers pay their taxes to a greater extent than the services that they receive in return. So everyone has skin in the game. The problem is I don't want to be paying $1,300 out of my pocket every year, and I don't want you to do the same, simply to fund the inefficiency and administrative waste that is fostered on the people of this country by the private health insurance companies. We need to get rid of them and run the system ourselves by society for the benefit of society.
Dr. Wilson.
It is nice to say that Big Brother should take care of us. It doesn't work. I gave you the numbers where Big Brother actually takes care of you and your care is worse. It is nice to say that government should do something, but government rarely does what it promises. Do you want government employees, not even physicians, making your healthcare decisions? I don't. I gave you the example with breast cancer, and that is an example that hurts poor women, not rich ones. Look at examples of large government institutions. I gave you the three largest, of which healthcare would be even larger, and each one of them is bankrupt. You can't keep pushing and pushing and pushing a bankrupt system. It won't work. I'm afraid you don't listen to the newspapers. If you know about Greece, it's actually called pigs, because the same thing is happening in Portugal, Ireland, Italy, thank you, Greece, and Spain. They're all going broke because of their social welfare systems, and that's what you want to push on us. We're already $1 trillion in the hole just this year. Remember the example I gave you of the Indian Army, the Chinese Army, the Indian Railway Service, and the British system. If we adopt that, we will have the largest bureaucracy of all of those combined. Remember compassion. Compassion was the purpose of this debate, and 3 of the 4 people, at least on this panel, have said that government is not the place for compassion. Thank you. Thank you.
Dr. Roland.
I learned that I was asked to participate in this debate a week ago, and when I started thinking about it, what I did is I looked at how my interactions with the healthcare system happen on a regular basis. I looked at my own home, and this little book, we get our insurance through my wife's work. I was trying to figure out what health plan we should choose. It's the most confusing, crazy waste of time that somebody developed all these different plans and their variations and the variations on the variations. I practically cried when I saw my patients are going to have their insurance, revoked because the mother didn't say on her form that her daughter had a urinary tract infection. I have a patient who's been off work for a month. Why is she off work for a month? Because her depression was untreated because it was because of the delays that it took to get her insurance company to approve her antidepressant treatment. I've had another patient off work for many months because the workman's compensation insurance said it was the regular insurance that should pay for it, and the regular insurance said that it was the workman's compensation. This is ridiculous. A unified system would work so much better. I had another patient who told me this week, who came to me with a lump in his neck. I said, why didn't you come see me sooner about this? He said, because I'm applying for health insurance, and I didn't want it to be a pre-existing condition that would keep me from getting health insurance, and I knew I had something bad. It's just, I spent 10 minutes on the phone with another patient after trading phone calls 3 or 4 times just to figure out whether he should go to lab A or lab B because his insurance has changed. Half the new patients I get are because their insurance changed. I have now 250 patients out of my panel who are leaving because their insurance changed. It's insane, and we need to have unity and a system that works.
All right. Thank you to all the speakers. Now for the moment of truth. If you would like to vote for the federal government being able to provide the most compassionate and efficient health care plan for America, please use the green card. For the free market, please use the blue card. If you're in the middle or undecided, please use the red card. We need more green cards in part of the room, apparently.
Out of green.
Please raise your hand if you don't have a card you need to have.
Trying to be focused on
for 2 up close, but I thought we had complimentary approaches. When should we do it again?
Is there anyone else who does not have a card that they need? There's a gentleman over here on the right and a lady over here on the left who both need a different colored card. Please keep your hands up if you would.
Where does she live?
Yeah, I'm from Ottawa.
She lives in Montreal.
Oh, she's from Montreal.
Yeah.
Cindy, there.
Were you born here or you're an American?
I'm born in, I'm an American, but she's a Canadian citizen and lived here for 25 years. And
went home.
when my
Okay, we got everybody?
passed away in 1970, she went back 5 years later. She went back to Canada.
All right, everybody has the card they need, right?
So they would have just been rolling it.
Okay,
They would have just been rolling it.
I'm just saying, come down and see how.
ladies and gentlemen, I want to thank you once again for, if I can have your attention, please.
Some of the elements.
I want to
78.
You guys are excitable this evening. It's a pleasure to be here. I want to start off with, can we have a round of applause for all 4 of our debaters, please? While we tally those up real quickly, I wanted to also introduce John Webster, who is the head of the Benjamin Rush Society chapter here at Stanford. If anybody would like to, if anybody's interested in hearing more about the society or potentially joining the Stanford chapter, John is the man to talk to. We're going to have a reception to follow, and anyone is welcome to join us. We hope you will, right outside here. While the tallying is being added up, Bo Breeze is handing out Benjamin Rush Society brochures, and if you'd like any extras, again, they're up here on the table. Benjamin Rush Society is an organization that supports the liberty of the doctor-patient relationship, and we're also very committed to staging these sorts of high-level debates at med schools across America and encouraging a high level of exchange of ideas about this important topic. And I want to lastly hand this back to Bo once he's done handing those out. Bo Breeze is a resident here at Stanford, and he did a tremendous amount of work in putting on this debate. If we could give Bo a round of applause.
224 years ago, Benjamin Rush signed a document that put his life at risk for the sake of the legacy of this nation, and that document was the Declaration of Independence. We are all heirs to that legacy, and it's a legacy that I hope with all of my heart can be found especially at the university. We're a universe of ideas, liberal and conservative, libertarian and socialist, can find both voices and ears that are listened to respectfully so that we can answer the most critical questions, indeed the questions upon which our very lives and the lives of our patients depend. Thank you so much for being part of this movement, and thank you so much for being here tonight.
I think they're coming.
Okay, I have a correction. The reception is upstairs. You probably knew that for the most part. All right, so in the pre-debate vote, we had, I'm sorry? Oh, I just have to read off the results. These are hand counted. This is not a high-tech operation here tonight. Okay, in the pre-debate vote, we had 57 votes in total, 25 votes for the federal government, 20 votes for the free market, and 12 undecided. In the post-vote, we have every vote will count. Still have votes trickling in, apparently. In the post-vote, we have 54 votes, so just 3 fewer. We have 30 for the federal government, 20 for the free market, and 4 in the middle. So 25 to 30 federal government, 20 to 20 free market, and 12 to 4 undecided. So there you have your tallies. I want to thank everyone again for coming. I hope you'll join us at the reception, and have a good evening.
Thank you. Good debate. Good debate.
What we did in Long Beach is we actually set up systems through with the city